Before I begin, I'm very sorry I'm not able to be with you in Pittsburgh this September. I have a significant birthday this month, so it just wasn't to be. But I look forward to hearing back from colleagues on the visit. I was actually reading an article this morning about Picklesburgh and the giant inflatable pickle over Roberto Clement Bridge, if that's how you pronounce it. But I believe that festival is in July, so perhaps next year. So, to introduce myself and my talk today, my name is Jackie Erdman, and I am Head of Equality and Human Rights in NHS Greater Glasgow and Clyde. Just to give you some idea of my organisation, which is huge, we serve a population of 1.14 million people. We employ around 39,000 staff. We have 242 GP surgeries, 35 hospitals of different types, dental services, optician services, and 50 health centres and clinics. We also have more than 300 pharmacies and an annual budget of 3.1 billion. We cover 6 local authority areas, as we call them, so we have 6 local democratic structures to work across. I'm going to talk to you today about our approach to equity in health, and stigma and discrimination as a social determinant of health, or what Fellon et al. Called a fundamental cause. You may be familiar with this diagram, which proposed that the factors that can impact on someone's health aren't just about biomedical disease, genetics, but where you live, how much money you have, your social supports, and the political environment can all shape health and have led to stark and enduring health inequalities. A very famous GP who worked in Wales and actually sadly died only this year was called Julian Tudor Hart. And he noticed what he called the inverse care law, so that those most in need of health care are least likely to receive it. So we're interested in the cause of ill health, which are as a result of factors beyond the health service, but also how people can get equal access to treatment and care. As I've mentioned, Fellon et al. Have written about social position as a fundamental cause of health inequalities. So they argue that while diseases have changed over the decades, what has persisted is the association with socioeconomic status and mortality, and also years lived and disability. They went on to identify stigma as a fundamental cause of health inequalities, also linked to our position in the social structure, which leads to unequal access to resources and to higher risks. So, for example, our ethnicity, our sexual orientation, whether we are male or female. In NHSGGC, we have a diverse and changing population, particularly in relation to ethnicity. Our Black and minority ethnic population is much younger and is also growing, so we now have 25% of under 5s from a BME population. We also have high numbers of gay, lesbian, bisexual and transgender people living in our area, partly through gravitation to cities, which can sometimes provide a safer environment, in some ways anyway. We have higher levels of poverty and child poverty, driven by unequal access to power and resources. For example, single parents who are mostly women. So this has implications for our population's health and how we deliver services in NHSGGC. And not just NHS services, but all social provision, including welfare, housing, leisure, employment, and so on. So discrimination can happen on 3 levels. Institutional, where organisations' policies and practices exclude or limit participation. Cultural, where prevailing beliefs, attitudes, assumptions, practices and behaviours can adversely affect the experience of different groups. And personal, where our individual values, attitudes and beliefs can adversely affect professional actions and behaviours. I'll come back to this and how we assess this in our organisation to identify and eradicate discrimination. So, defining our terms and the context we work in my organisation, equality means making sure people are treated fairly and given fair chances. This isn't about treating everyone the same, but it recognises that our needs need to be met in different ways. Inequality refers to the experience of discrimination and oppression. It's concerned with differentials in the allocation of power, wealth, status, resources, and equality of opportunity. It relates to poverty, but it's also associated with social status of other forms. And equity, so the quality of being fair or how institutions behave. Finally, the legal context that we work in the UK and what is called the protected characteristics. So these are the groups defined in the law, and the law that we work under is the Equality Act 2010. So here are the groups defined under the law, which will be very familiar to you. So the Equality Act 2010 brought together over 100 pieces of legislation designed to protect these groups from discrimination and prejudice, to promote equal opportunities, and to engender good relations. This legislation is often used in conjunction with human rights legislation, and in fact a lot of it came from human rights legislation. So, this is the document which my organisation developed to tell our public what we will do to become fair and equitable. We have two sections in the document. Firstly, mainstreaming, so where we have objectives we want to achieve across all of our services. And then we have specific outcomes, so this is where we want to make a difference for particular groups. This document was based on current evidence and wide engagement with patients from equality groups. And what our patients said to us was that these were the most important things to them in terms of their health care. That you will know something about me, that you will communicate with me, for example, making sure you have interpreters, that you will give me more time, that you won't make assumptions about me based on your attitudes or misconceptions, that you'll make sure I have access to services on an equitable basis, and that you'll meet my additional needs. This is a poster we made to express this to our staff. Often our staff say to us, we don't discriminate because we treat everyone the same. However, what our patients are saying is, no, look at the person in front of you, understand what their life is like, and meet their individual needs. So I'm just going to give you some examples of what our approach looks like in NHSGGC. In Scotland, 6 in every 100 people are lesbian, gay or bisexual, and as I said, it's probably higher in our area due to the size of Glasgow City. We developed I'm Taking a Stand campaign to challenge homophobia across our organisation, and I'll show you a picture of that in my next slide. We predicted that 1 in 20 appointments could require some form of communication support, such as interpreters. We now have over 500 supported appointments a day across all services, including British Sign Language. We have the biggest in-house interpreting service of any NHS organisation in the UK. A quarter of children in our area live in poverty, and in some neighbourhoods it's much higher than that. We've raised £20 million in unclaimed benefits and goods for families through our Healthy Wealthier Children project. That's over the last 7 years. And the way that works is that midwives and health visitors can refer their patients for money advice. In 2014-15, there were almost 60,000 incidents of domestic abuse recorded by the police in Scotland. Our staff routinely inquire about domestic abuse in appointments, and we have trained staff to respond if somebody discloses abuse. One of our areas, Western Bartonshire, found that they had exceptionally high levels of domestic abuse, so they're taking a preventative approach. So they're trying to really stop domestic abuse before it happens, a very interesting way to work. So this is our Take a Stand campaign, and this is staff and volunteers at the LGBT Festival Pride. We've actually just developed rainbow lanyards, as you can see, and we're hoping that staff will wear these to try and raise awareness of the needs of LGBT staff and patients. And here is an example of our work with the deaf community on their rights to communication support. We actually have a new piece of legislation in Scotland which recognises British Sign Language as a language and acknowledges the deaf community and their culture. And this piece of legislation is actually unique in the world. So this poster tells patients that they have a right to a BSL interpreter, and then on the back it tells staff how to book an interpreter. I said I would come back to how we assess risk and the needs of equality groups, and we have a very robust equality impact assessment process in NHSGGC. There are many types of impact assessments, and you probably will use many of them. Our process is used to assess the organisation's policies and plans, and also the patient pathway, to understand the barriers to services and to address unequal outcomes. Finally, human rights, which underpins all of our work. We all have the right to be treated with dignity and respect, but it's clear that discrimination and prejudice fall under the Universal Declaration of Human Rights, and they are very relevant to some particular health services, for example, mental health, dementia services, and prison health. I'm going to leave you with this image. In the first picture, some of the people can see the game and some can't. In the next one, we've met some people's needs, so everybody can see the game. But in the final one, we've completely removed the barriers so that everyone can see the game in their own terms. So, thank you for listening. And here's our website, which I would recommend to you, and my contact details for information. Thank you.